Greetings, everyone. I'm Dr. Georgiana Luisa Baca, and I work in the Interventional Cardiology Research Department at Barts Heart Centre in London, UK. Thank you very much to the EACTA committee for its generous invitation to contribute with a webcast specifically dedicated to explore the relationship between the novel COVID-19 disease and the health of the cardiovascular system. During your busy schedule, I'm especially grateful to each and one of you for giving me the opportunity to share my local practice and snapshots of medical literature to help us navigate this topic. I have no conflict of interest. The opinions I express in this webcast are mine, and not necessarily those of the EACTA committee, nor of any national or international institution that I might be mentioning in this presentation. We're all connected. We've seen it with COVID-19, and it's also reflected in my list of collaborators. Dr. Maria Benedetto has introduced me to the EACTA. She's an experienced anesthesiologist and intensivist in Bologna, Italy, and a role model for women in healthcare. Prof. Anthony Mather leads the Interventional Cardiology department at Barts, and he has generously offered his mentorship during the preparation of this presentation. The other members of the Interventional Cardio team at Barts have provided further case-based local clinical insights. Dr. Mary White leads the ICU team at Barts. She has provided extraordinary support to all cardiology doctors deployed to work in the ICU department during the COVID-19 pandemic in London. She has also given me constructive feedback for this presentation. This webcast has been reviewed on behalf of the EACTA committee by Prof. Stephen Rex from the University Hospital in Leuven, Belgium, to whom I am extremely grateful for his constructive feedback. To get started, here is a case we've seen in our center. It would be great to discuss it together. It's mid-March 2020 in London. Mr. A is a 58-year-old man of British Asian background who presents to his local hospital. This is a busy general hospital which covers a large and diverse population of the city. Mr. A has had difficulty in breathing and has been coughing for the last 5 days. On arrival to A&E, he is found to have an oxygen saturation of 50% on room air. His past medical history includes type 2 diabetes, hypertension, high cholesterol, and he is obese. He is not known to have ischemic heart disease, and he's been taking regularly optimal primary prevention medication. He is also a non-smoker. Besides the highly abnormal oxygen level, Mr. A looks normal. This is probably the first sign that worried us. His ECG shows sinus rhythm and there's subtle septal ST elevation. The trop is above 600. Mr. A's chest X-rays comes back and is highly abnormal, with bilateral consolidations. Soon after, his COVID-19 swab tests positive. Since admission, the patient has been on high-flow oxygen and continuous positive airway pressure. Unfortunately, his most recent gas indicates a clear deterioration in the respiratory function. He is consented for urgent intubation. While ventilators are available, there is a limited number of beds and a shortage of nurses in the local ICU. The patient has to be moved to a bigger intensive care unit. By now, a new special COVID-19 designated hospital has been organized, and Mr. A is one of the first COVID-19 patients transferred here. The environment is new both for the patients and for the medical staff taking care of them. While there are obvious challenges in adaptation in the midst of an international crisis, there are moments when we get a feeling that working on an extended multidisciplinary team has significant advantages for patients, and this new space, designed for purpose, is easier to navigate. You have a 58-year-old man who has been intubated for COVID-19 related respiratory failure. 18 days since his admission, you know that he is difficult to ventilate. What tests or what interventions would you like to do at this point? In our team's case, we opted to conduct a CT pulmonary angiogram. The CTPA showed pulmonary embolism. We treated the patient with enoxaparin. Mr. A has been admitted due to severe COVID-19 disease. He was in respiratory failure, so he was intubated. He has required multiple episodes of proning. In addition, he has received pulse methylprednisolone. This was followed by decreasing doses as per local hospital protocol. Mr. A also has bilateral pulmonary embolisms, so he is being treated with enoxaparin. On bronchoscopy in the ICU, we've noted an edematous airway, therefore started him on dexamethasone 6 mg once a day. He is likely to require a trachea. At this point, he is 20 days since admission, and something happens. We note that he has deep anterior lateral T-wave inversions. The bedside echo confirms that the LV is moderately impaired, and there seems to be regional wall motion abnormalities. The ICU. We have a stable, critically ill COVID-19 patient with a long ICU admission, who is still requiring ventilation for respiratory failure, but he is making slow progress. He has multiple cardiovascular risk factors, and, not uncommon, unfortunately he develops acute myocardial injury. This is demonstrated by dynamic ECG changes, abnormal cardiac markers, and an abnormal echo. So far, this sounds like my typical cardio to ICU consult. Based on the territorial ECG changes in particular, I would normally be inclined to consider that the patient has pre-existing coronary artery disease. While that's still the most likely explanation, now there seems to be not only a novel virus, but also a novel cardiac question. Could COVID-19 be the direct cause of this patient's heart disease? This is the most complex slide of the entire presentation, so please bear with me. SARS-CoV-2 is the coronavirus causing COVID-19, the disease. The task is to establish if SARS-CoV-2 can directly affect the cardiovascular system. First, I would like to emphasize 3 important initial observations. 1. Patients with cardiovascular disease seem to be particularly affected by SARS-CoV-2. 2. SARS-CoV-2 enters the cells by binding to the host receptor angiotensin-converting enzyme 2, ACE2. ACE2 is expressed in the lungs, heart, and blood vessels. 3. In severe COVID-19 cases, the body's immune response is defective. It overreacts. In milder or asymptomatic cases, there is a healthy immune response. There is scarcity of data on this topic, particularly in humans, but it's fair, given the urgency of the situation, to use inductive reasoning in order to guide our next steps to protect our patients. So here's a diagram describing the interaction of SARS-CoV-2 with the immune system. SARS-CoV-2 infects cells expressing the surface receptor ACE2. The active replication and release of the virus cause the host cell to undergo pyroptosis. Pyroptosis is a highly inflammatory form of programmed cell death. The molecules released by the virus-affected cells activate neighboring cells. These release proteins which attract monocytes, macrophages, and T cells to the site of infection, promoting further and establishing a pro-inflammatory feedback loop. Now, this is the important step in the diagram. In a defective immune response, this may lead to further accumulation of immune cells in the lungs, causing overproduction of pro-inflammatory cytokines, which eventually damage the lung infrastructure. The resulting cytokine storm circulates into other organs, leading to multi-organ damage. Alternatively, in a healthy immune system, or better said, in a healthy immune response, the initial inflammation attracts virus-specific T cells to the site of infection. These can eliminate the infected cells before the virus spreads. Neutralizing antibodies in these individuals can block viral infection, and alveolar macrophages recognize neutralized viruses and apoptotic cells and clear them by phagocytosis. Altogether, these processes lead to the clearance of the virus and minimal lung damage, resulting in recovery. Well done. Angiotensin II is pro-inflammatory. ACE2, on the other hand, plays a major anti-inflammatory role by converting angiotensin II to angiotensin 1-7, which carries anti-inflammatory properties. Cardiovascular disease associated with COVID-19, it's likely to involve dysregulation of the renin-angiotensin system, ACE2 system, due to SARS-CoV infection